information presented is in no way to be considered as a standard of care, and the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The information is provided with no guarantee. All content is for informational purposes only and does not constitute providing of medical, legal, or regulatory advice.
All right, good morning, everybody. Welcome to this edition of Blue Crew Medicine. Today we're going to do pediatric toxicology, a little bit of Peds Tox. So today I've got joining me is Dr. Matt Moretti, who is joining us again, Peds EM Fellowship Director, Peds ER attending, friend of us over here all the time. And then I got a couple of newbies coming to the podcast who I've worked with for years. But Paul Boackle, Air Care Flight Nurse, or BFN, and then Brad Johnston, who is just Brad. One of the Air Care CCPs. Both of them work out of here, out of Air Care 1 in Jackson. So today, let's get right down to it. Peds Tox. When I think of Peds Toxicology, personally, I think of something that's complicated and something that makes me think. It's not something usually that's really simple. Some of them are super simple. Hey, they ingested this, or hey, I walked into this, or they were exposed to different things. But it can get really complex and really, really quick. So for us today, since there's such a wide variety of topics, we're going to kind of break it down in between environmental tox and medication-induced toxicology. So getting right down into environmental stuff. Biggest thing from the get-go is decon before they get to the ER or before we get in the airframe.
Absolutely.
We see it pretty regular. People will come in and they haven't been able to get decon. If they come in POV, that's one thing. But if they're coming from another medical facility, if you're out in the field EMS, try to figure out if you can decon them before you do that. Mm-hmm. What are y'all thoughts on decon?
Yeah, so this is something he and I had talked about. My background before I came here was firefighter. So one of the things they taught us when we were going through hazardous materials training was utilizing, what we have on the trucks to decon people. So, if you had a mass, a mass casualty incident where a lot of people got exposed to a substance, you could utilize a fire truck, an elevated stream off of the ladder and have them walk under that, as they're coming into the bay or coming in, outside of the ER. It's just an easy way. It's gross decon. You're not going to get all of it, but that will get the majority of what you need done. Just a quick gross decon. And then that can also, when you're talking about triaging patients, if they're able to walk underneath that, well, then they're walking wounded. For the most part, their airway is good at the time. Their mental status is good if they can walk. So, utilize your resources. We have a fire station. JFD has a fire station within 2 minutes of the hospital here in Jackson. I believe it's Station 5, I believe. Mm-hmm. So you could activate them early. That's something to think about. Just, utilize your resources. You have MedCom here in the hospital is a fantastic resource for, if you need DEQ. There's a group out at the air base, I believe the 47th Civil Support Team. Mm-hmm. That's mainly what they deal with is hazardous materials, whether that be nuclear, biological, radiation, any type of toxic substance. That's the kind of stuff that they're trained. That's all they do is that type of stuff. So that would be a good resource. They have all types of equipment that we don't have here at the hospital. So just, try to think a couple of steps ahead and utilize your resources where you think you might need them. If you can always send them back if you don't need them. So.
I know kind of from a transportation aspect of it, and Brad kind of touched on this, I think communication is key all throughout, whether it's talking about whether they've been deconned or what they may have been exposed to. From that aspect at your patient contact point all the way through, it may be calling, poison control. It may be, calling to the Peds ED to get a consult just to let them know, hey, we're not sure, but this is what we suspect. We do have decon assets here in the emergency department at the intake. I can remember years ago, not specific to Peds, but back when anthrax was a significant concern and a lot more common scares, the EMS crew took this patient that had a suspected contamination and put him right in the back with them. No mask, no gown. Literally all they had was gloves, and they drove all the way here. And then at what point they said, okay, well, now everybody has to get out and disrobe. But I do think, just as a additional consideration in the pediatric population, whether it's gross decon or otherwise, regardless of where it's done, you got to pay attention to thermal stresses and, cold stress in those people. Even in warmer days, those kids may get, some thermal exposure that might not be quite as big of a deal to an adult to get hosed down. With a kid, it may make a difference, and we could see a change in vital signs afterwards. So,
yeah, I think if you look kind of guideline recommendations for any chemical exposure, be it powder, gas, liquid, whatever, so any sort of contaminated chemical exposure, especially in the pre-hospital setting, thinking about decon early and not even having to get complicated, literally just they get completely disrobed, and if you have the ability to wash them down, you wash them down as soon as possible, and you just don't carry any of that with you. Yeah, there's lots of stories, Paul, about EMS crews trying to do quick thinking like emergent care and transporting sick patients to institutions and having harm from it. Nobody with a chemical on them should be put in the back of an ambulance, or certainly not in the back of a helicopter, still wearing the clothes that they had on the ground, taking those things off rapidly. This is one of the reasons why fire trucks and ambulances have always kind of recommended carrying blankets with you so that you can have these events. Stripping them naked down to their skivvies and trying as best you can to wash them off, and then putting them in a blanket before you transport. Definitely, pediatric patients are going to be a little bit more vulnerable to outdoor temperatures, especially if you are successful in washing them off. But put them in a blanket, turn up the heat in the back of the ambulance, or as best you can in a helicopter can make a big difference there. But pretty much anything you get exposed to worsens the longer it's there.
Sure.
And so getting that crap off extremely early, and I agree, call ahead, because whether or not you did a super thorough job at the scene, they still need to be rewashed when they get to wherever they are, because if the emergency department does have a decon unit, which a lot of places do, it may just literally be a shower stuck in a room somewhere that has a special reservoir that keeps the dirty stuff, but a lot of places have a shower to wash contaminated patients. They need to go in there pretty fast. Most of the things that are in this category of like dangerous to transport kind of stuff, you can decrease exposure tremendously just by running them through some water and taking their clothes off pretty rapidly, and can improve outcomes substantially just by not even getting complicated. Just take the clothes off, wash them down.
Be simple with it. The other thing I wanted to bring up is the ERG book. So there's that bright orange book that most people may not be familiar with. I'll put a link here in the comments, but there's actually an app for it now. It's not quite as painful to tote around, but those ERG books, you can literally look it up, chemicals by any different way, and it'll tell you how to decon them. It'll tell you how to expose them, how far you need to weigh. Most people use the thumb rule as far as hazmat, where you're approaching the site. So if I can cover the site with my thumb, great, I'm far enough away that makes me feel good. But you still got to figure out how to decon those patients if you know the material. Now, those patients you have no idea what it is, usually water is a great answer. Just generally strip them, get them clean, get them as rid of the substance as best possible. But that ERG book is a great reference. We use it in the ERs. We have them in the airframes. Again, there's an app for that, and it's a great tool to figure out, hey, what's the best route to make sure I get it off effectively.
Yeah.
Sometimes you're literally, like we're talking about some different substances before we started here, you may have to take a towel and literally just sit there and wipe them down, just like you would nitro paste off somebody's chest. Just literally just sit there and rub them down.
And a lot of our listeners, I think, it's important to communicate. This is not, it's not as obscure as you think. We've worked car wrecks tons of times where just gas got on them. Well,
covered in gasoline.
It's a hydrocarbon, and it's on their clothes, and if it's in a closed space, it's gonna, as it vaporizes and they're breathing it in, they could have not really inhaled any of it on the scene, but then you put them in a closed space, didn't take off their clothes, and now, they've got inhalation of hydrocarbons.
And so do you.
Yeah, absolutely.
And I think that's the other piece to that is, they teach you from the very beginning at pre-hospital is secure the scene, right? If you carried the scene in the back of the truck with you, that's not real secure.
Yep.
Well, and something a lot of us found out during COVID, even ambulances, a lot of them have an exhaust fan or exhaust vent on the switch. Does it actually recirculate, or does it truly exhaust it out of the truck? We had an instance here, one of our trucks. We thought it exhausted and actually recirculated.
Yeah.
So make sure you understand your equipment or what you're transporting them in. You brought up hydrocarbons. Let's just go right into household items, which a lot of them we deal with pretty frequently, I think, in PZR here. But when I think of household items and stuff, especially stuff kids get into, everything in the kitchen sink, most everybody uses the locks or some of we've got the little plastic tabs at our house. But anything to keep them out of the Drano, the soap, the Murphy oil, the Pine Sol, but any paint thinners is one of my favorite ones. But any of those household items, when you guys think of household items that stuff can get into, what do y'all think of as far as management and exposure? You might see something, hey, my kid's just not acting right. What makes you think that?
So there's a few big categories that we kind of try to group things into. Hydrocarbons are kind of the first big one. So things like paint thinners, your WD-40 kind of stuff, Pine Sol, like Murphy's oil, all those types of oil-based kind of things that are really there to be hydrocarbons. So hydrocarbons are a major player still to this day in pediatric environmental tox. We see it quite a lot. Comes up on the, our fellows are doing like training on this. We've been doing a lot of board prep. So there's a lot of board questions about it. It comes up all the time on the emergency medicine boards too. So hydrocarbons pretty common. So being aware that you have them first is kind of actually a big point, because a lot of people don't realize what they have is a hydrocarbon. A lot of they just don't even know that kind of is that toxic. Good thing about hydrocarbons is you can kind of tell how bad it's going to be based on how thick it is. Most of the time, the thicker, hydrocarbons are going to be a lot less dangerous because they're going to stay in the stomach, and they usually taste pretty bad and they smell pretty bad. So they're not as ingested as often. It's the thin stuff like paint thinners, gasoline, that really kind of create major issues because they're volatile first off. So like Paul mentioned, when he's talking about the gasoline on the car accident victim, you're inhaling all that. And it can have profound CNS effects, very significant respiratory effects. Not as many people think about the very important like cardiac activity that hydrocarbons have, which we can talk about in just a second. But the thin ones are easy to vomit, so you aspirate really easily, and they tend to be volatile, so they are already getting into the lungs in the first place.
And they look like juice.
And
a lot of them look like juice.
Yeah,
so
look like
kids
apple juice.
Yeah, kids are super familiar with them. Pine Sol is one.
They put smells in them too that make them smell nice.
Yeah.
So they are super dangerous. Chemical pneumonitis from the respiratory effect, whether that's because you inhaled the gas or because you aspirated it.
Yeah.
Both big deals. We see it a lot in kids. Getting them out of the space and away from the chemicals, like rule number one. So if it was a spill type accident, you just kind of pull them out and just clean them off, get them away from it, take their clothes, get all that hydrocarbon away. If it was more of an ingestion, do what you can to make them not throw up. So this is not please God, don't give them syrup with Ipecac. Don't stick your finger down their throat. Don't do any of those things. We still see people come in having tried to make the kid vomit. Activated charcoal doesn't do jack, and it's going to make them throw up. So don't do that. We see those a lot. They tend to not be super early presenters, which can be really scary because they look fine for the first few hours. Plug for poison control. Poison control recognizes this. They're going to tell you got to watch them for 6 hours. If you try to send a hydrocarbon ingestion or exposure home in 2 hours, you have not watched them nearly long enough to feel safe. So getting them out of there quick is a bad idea.
Can go into the cardiac effects.
Yeah,
I've got a reason.
This is really important to me because we've seen several instances in the past few years where this has kind of become an issue. So hydrocarbons, when they get in there, they actually cause some catecholamine surge. They hyperactivate the cardiac muscle. So if the patient were to have a cardiac arrest, which is usually because of respiratory causes, in most cases you either let them get terribly hypoxic and so they arrested, or you like super stress them out, and so because of the catecholamine surge in their heart muscle, they went into an arrest. Everybody pretends like it's normal and it's a normal cardiac arrest, and so they give like normal doses of epi and epi and epi and epi and epi and epi. And what we actually know from a toxicologic standpoint is epi is actually really bad for the hydrocarbon cardiac arrest. It can throw them into malignant dysrhythmias that you can't break them out of. So most of the time the actual recommendation is about a tenth of a dose. And so it's that thing that we always used to do, like epi spritzers, right? So figure out what their regular dose of epi is and give them a tenth. So if you're talking adults or adolescents, instead of pushing the whole Bristojet, you just push 1 ml. Much of the time that's enough. And the longer you do that and the more you are pushing high dose epi, the less likely you are to actually get this person back.
The other part of that is, you mentioned making them not throw up. A lot of people were like, okay, well, I'm going to give them a whole bunch of Zofran so they don't throw it up, or this, that, and the other, and then you end up with a QT.
And then you got a QT prolongation, and then you've got like...
And then you throw them into this
multiple
whole arrhythmogenic
Yeah.
storm thing that ends up being a really bad day. I've seen that once in my career, and it was a very not pleasant
Paying
experience.
attention to the heart part of hydrocarbons is really, really important.
And I think people, maybe to kind of dovetail in with that, I don't think a lot of people realize how small of a quantity, like a couple tablespoons could do it in a kid, right?
Yeah. So depending on the type of hydrocarbon you're talking about, it can get pretty bad. Some of the fatal alcohols like methanol, like people still have sternos in there. I have, camped with them before. So you got a great big hydrocarbon sitting there. Those things are greater than 50% concentrated. So for a kid, usually 1 gram per kilogram is going to be more than enough to send them into pretty serious toxicity. And so we're talking like in a kid less than 20 kilograms, you're probably talking like 5 to 10 mLs of one of those sternos. And if you did have like a true 100% methanol or 80% methanol kind of fuel, it's less than a mouthful. And so less than a mouthful, all they got to do is dip their finger in it, suck on their finger, and they've had enough methanol to have a very, very profound toxicity.
So working through household items a little bit more, let's go through some of the chlorine stuff. A lot of people in Mississippi, we all have pools. A lot of people there's 2 things that come to mind with chlorine. One is the gas, if you get somehow it's aerosolized or what have you, but also the tablets or the gel packs I've seen now. Those are something that, again, it's kind of like the Tide Pods. They're pretty colors, and they're like, ooh, this is candy. I'm going to take it.
This looks like a big Altoid. Yeah, I mean, we had just recently the big chlorine gas exposure and had to deal with that. So, yeah, I mean, fortunately, knock on wood, most homes that use chlorine to manage their pools don't have indoor pools. Most people. Now, that's not everybody, but most of these places are outdoors. And so in general, as long as you don't have like the liquid doesn't get all over you or something, which would be bad, then you're pretty safe. But like these indoor pools, like at YMCAs and at, your different types of gyms or things like that, that's always a potential risk. Chlorine gas is super bad. Like anybody with military experience has had to go through training on, the dangers of it, what to look for on the battlefield, stuff like that. This is one of the blistering agents, right? And so I kind of think about it, everything burns, right? So your eyes burn, your skin burns, your lungs burn. They come in super stridorous, lots of wheezing and coughing. Their eyes are burning. Their skin is usually a little bit red, and eventually it will blister. This is another one of those things. Don't throw this in the back of your ambulance until you have taken their clothes off and washed them off. And it can be that gas and the liquids that kind of people use to make it. You can get really, really sick in a really quick hurry. And we saw that, just recently with the chlorine gas exposure.
And I want to back up.
Yeah.
The first managed treatment with chlorine is oxygen. Just flood them for the most part.
Yeah, I mean, I would say the first is decon.
Well, decon. Okay, back up. Decon. Yeah.
Decon them first, and before you ever even stick them at the back of your fire truck or the back of your ambulance or the back of whatever, wash the heck out of them. If they manage to somehow make it all the way to the ER before anybody did anything, they need to get washed down before you mess with them, because everybody can succumb to that chlorine gas.
Well, that's, we had a crew member exposed to chlorine, basically a chlorine explosion at his home. He was mixing some stuff to put in his pool several months ago. It'd been great if we could have talked to him about that. But anyway, it exploded directly into his face, and it was a significant enough explosion that neighbors heard it. He ended up in the ICU intubated, and I think the only reason he had as good of an outcome as he did is he immediately, when it happened, staggered and luckily found a water hose and deconned himself for 10 minutes waiting on the ambulance, just continually deconning, his face. And he still ended up, as you said, he came into the ER stridorous, wheezing, red, starting to blister, and ended up getting, electively intubated for airway protection because they were concerned with his airway swelling. So, yes, decon and then, the oxygen, that was...
Get him on oxygen early, definitely can help the situation. These are people I'd probably, if you're out in the community and, you're a helicopter crew having to go pick that person up and transport them, these are probably people that you consider elective airway control pretty early if they're having a lot of upper airway issues already, because everybody knows it sucks to intubate somebody, at 10,000 feet. So, don't do it. So just before you take off, kind of those things. But early oxygen, if they are having true already blistering, consider insensible losses, like burn care kind of stuff. Fortunately,
one thing we targeted really well with, I've targeted a couple of times, but with the incident Brad's talking about was urine output, making sure the kidneys are still functioning and everything else, because it is an interstitial loss thing. It comes out kind of like a burn.
Yeah,
right up.
Absolutely. The ingested chlorine, they get sick as stink, not from they just vomit and won't stop vomiting, and their body is heavily rejecting that. And then you can unfortunately aspirate that. There's tablets, or if it's the liquid, you can aspirate that liquid, and it just does terrible things to your lungs. They can go into just terrible, terrible ARDS, chemical pneumonitis, end up on ECMO.
I was going to say VV ECMO is one of the case studies I was reading in prep for this. They're like, yeah, we went to VV ECMO within 12 hours.
Yeah, it can go fast.
And they it was a kid ingested about half of a chlorine tablet from a pool and aspirated it, and lungs were smoked.
Yeah, they end up on ECMO for a long time.
When we start talking about other things in the house or other environmental stuff, carbon monoxide, house fires, it's yesterday in Mississippi, for those of you listening, it was 31 last night at my house. It was nice frost in the grass. So carbon monoxide, cyanide, both coming along with house fires. Super common. We see it all the time. I'm sure we'll see it again this year. Unfortunately, carbon monoxide is one of those environmental things. Get them out of the environment first.
Yes.
And then flood them. Biggest thing is flood them with oxygen best you possibly can. Make sure they, to the point we keep talking back on decon, but make sure you take off their burn clothes. Make sure you take off of anything that
stops the burning process.
Yeah.
I mean, Mississippi per capita has more fire deaths every year than I believe any other state in the country. And a lot of that is we're so rural, a lot of poor people, they don't have smoke detectors. They don't have, they live in, bad environments. So we have a lot of people that end up, not even talking about getting burned, thermal burns, but they just inhale, smoke. As you said, cyanide, CO, and the thing is, a lot of the times, both of those can kind of present the same way, altered mental status, of course, respiratory depression, but we see a lot of that in Mississippi, a lot.
I think something to really kind of piggyback on that is that space heaters, people don't really think about it. There's a lot of great new technology out there on the the little buddy heaters and stuff like that, where they have detectors, oxygen sensors. If it falls below a certain point, it'll actually, cut off on its own, little propane heaters. But there's a lot of people that have older space heaters and, things that don't necessarily have a carbon monoxide or oxygen sensor on it. It's just, hey, it's got tip over protection, must be safe. Put it in the house, closed space. They go to sleep and, they're getting exposed to it for a prolonged period of time.
Or even in Mississippi, especially in the northern part of the state, there may be some of these older houses that have those big boilers still.
Yes.
And man, those things leak, or they don't have the right sensors on them, or whatever. Have a carbon monoxide associated with it. Everybody's sleeping at night when the heater's wide open.
Yeah.
Same scenario happened down there.
Yeah, I did fellowship training in the Midwest where winter there and winter here were 40 degrees different. And unfortunately, we saw way more carbon monoxide up there than we see down here, which is good from a down here standpoint. But unfortunately, most of them are related to house fires. But the other places we see them, people don't think about. You spend all day at the boat. You're sitting right by the motor all day. It's your boat, so you're going to drive the motor, right? Your little trolling motor just pumping gas all the time, and people get carbon monoxide poisoning from that. You can get it from grills. Anything that's burning a hydrocarbon produces carbon monoxide to some degree. So just kind of being cognizant of those things. Cyanide, Brad mentioned it. Fortunately, you really only see cyanide from plastic melting. So assuming it's not a house fire, you should really never have to worry at all about cyanide. But as we said, a lot of these are. If you've got piles of Tupperware in the house, that's the only thing, piles of old butter bowls that you use to kind of put everything in the fridge. The fridge, the microwave, all these things have plastic all over them. A lot of people's furniture has plastic all over them. And so if you're succumbing to the smoke, and so you kind of pass out in your house, all that smoke is coming from that melting plastic also has cyanide in it. And so at least thinking about looking for it is really, really important. And you don't need like a fancy test or anything like that. I think Paul and I have actually managed one of these. You were transporting him and I was at UMC, and we were just checking gases, and the kid had like crazy intense lactic acidosis. I think lactate was like greater than 15, and he was acidotic to less than 6.9. So we were like, yeah, this kid's got to have had and cyanide, and so just something simple like checking a gas and a lactate. If you're at your community ER, you don't need a cyanide test, you don't need any of those things. You literally just need a gas and lactate, because regular carbon monoxide fire exposure does not cause just really profound lactic acidosis.
Both of them cause that anaerobic metabolism to kick in, but the lactate increase, I didn't know this until a couple of years ago, and I know we've had a previous episode on this, but cyanide, the lactate will increase to like 8 or 10 within 20 to 30 minutes of the inset.
You won't see that ever with a fire exposure, like unless the body is already dead. You're not ever going to see lactates greater than 8. And so if, typically what we tell people is if your lactate's anywhere close to 10, you need to assume that person has cyanide. And again, protect yourself. Because that cyanide is something that they have also inspired. And so as you're bagging the patient or whatever you're doing, right up in their face to intubate them, they're just blowing cyanide gas into your face. And I know of EMTs and RTs who have had cyanide toxicity because of exposure to affected patients. So again, decon. Think about yourself too. So you got to keep yourself safe. If you've got a house fire, if somebody's succumbed, they're down, and just assume bad things from the pre-hospital setting. Get them disrobed, get rid of those clothes, take a wet towel, like you were saying, Will, and just wash their face off really fast, put them in one of your fire blankets, and then throw them in the back of the ambulance. And if you're the community ER person, one of the first things you draw is a gas with a lactate, because you can make a huge difference.
I would add one more thing is most departments and ambulance services don't carry kind of bridging back. They don't carry the specific carbon monoxide detectors, which I know Massimo makes them, and
I
I'm
think
sure.
some of the Life Pack 15s
Yeah, 15s have them.
Yeah.
But
The
just
spectroscopy
well,
versions.
just being very specific, just because your normal sat probes are just picking up on a specific wavelength of light, and it's only measuring bound hemoglobin. It doesn't tell you what it's bound to.
Yeah.
Whereas those specific detectors, so I would just stress to anybody at every level, don't stop giving the 100% oxygen with whatever it is, carbon monoxide or otherwise. We can worry about weaning them later on once we've been able to sort of drill down to what the problem actually is. And, if they're in a house fire and there was a lot of synthetic furniture, that's something that could, potentially add to the cyanide. But whether it's carbon monoxide, cyanide, whatever, continue to give them the high flow 100% oxygen. Even if their sats are 100, don't worry about weaning them. We can figure that out. That's a downstream issue we can wean.
I would actually say that's an even more important statement to those people who do have the coax pulse oximetry. It's not reliable. There's so much literature out there that says that photospectroscopic coaximetry is bad. Like, it's not good. It's not consistent, reliable. You can't trust it.
The studies are all done on healthy people,
Yeah.
not on
Yeah.
people that are actually burning.
Not on
that
sick
have
folks.
stuff on their-
Not on people who smoke all the time anyway.
Mhm.
And so none of that's particularly helpful. And so I would argue, if you're an EMS company owner, like, don't waste the money on it. Just put them on 100% oxygen and you're going to be fine. And let somebody else downstream worry about it. But even if you do have it and it comes up, quote, normal for somebody that succumbed to smoke inhalation in the house, like, don't trust that. Treat them, period. Just there's nothing. It's cheap. You're already carrying oxygen. Like, just throw the mask on, turn it all the way up, and then roll out of there. I don't ever. Those things they're not reliable enough to alter treatment to me. And so when we teach courses, and when I used to teach fire med stuff up in the Midwest, we just told them, don't even waste your time on that. If somebody asks you later what was there, we just put them on 100% rolled because they were sick, and nobody's going to fault you for it. And the difference you can make in getting their CO level down on 100% FiO2 is profound. You can drop 90% of their carbon monoxide in an hour on 100% non-rebreather. There's no reason not to.
The only reason I can think of is paraquat poisoning. And if they don't have that, they're getting oxygen.
They're getting oxygen. Everybody could get oxygen.
Real fast, the dose for cyanide, if you do have hydroxycobalamin or have a cyano kit, for adults it's 5 grams, for kids it's 70 milligrams per kilo, max of 5 grams. So the Lilly kits are usually it's 2.5 grams, but
I was just going to say one thing maybe to add with that is, if you administer that cyano kit, it's going to throw off, if you try to pull a carboxyhemoglobin later, it's going to throw all your measurements off. So, if it's possible, you could pull a coax, a gas, whatever, before you administer
before you give it.
Because that's something that the patient that they were both talking about that we flew. That was one thing. That was the first time I'd ever given administered cyano.
Yeah.
It was
Greenwood.
It was both of
yeah. And that was something that we discussed after was the effects of it, downstream. So if you could get I can't remember. I wish I would have pulled the chart. I remember them. I think they pulled
a gas about 5 minutes before we came in the door, and it was just printing out when we got there, and we brought the kit with us. And there was multiple patients from a house fire, and we ended up administering it to this child. And
I think we actually repeated it.
We did.
We gave a second dose.
We did.
We talked to Tox, and they were like, "Yeah, it's probably fine. Give them a second."
Yeah.
They, that kid had a lactate of almost 15.
Yeah. It was
really high.
Yeah.
Just something I want to throw out. Talking about CO. It does not take that much. I think I can't remember from back when I was firefighter. I think 500 parts per million is generally considered the upper end of a lethal, or the starting point of a lethal dose. I mean, it can get way higher than that in an enclosed. Enclosed area in a house fire, and everything in your house now is synthetic. Back in the day, years and years before any of us started doing firefighting, Nope, the firemen never wore masks.
Yeah.
Because everything was cotton, wool. It was not synthetic substances in the house, so the firemen didn't have to. They could breathe that smoke all day, and it didn't affect them as much. But now everything is synthetic. Is totally different. And anybody that works at a place that goes to fires a lot, they'll tell you that. The smoke is different nowadays, just because of the synthetic material. Stuff has hydrocarbons, synthetics, and the couches, the mattresses, all that stuff. So
Got formaldehyde in it too.
yeah, I mean, you mentioned refrigerators. The Freon, if that stuff burns, I believe it's phosgene gas. Everything synthetic is bad. It just and to your point, about the ERG book, a lot of these. I remember learning in hazmat. The most dangerous hazmat scene you could work is something like a Walmart truck or a FedEx.
FedEx truck.
Because they do not have to. They have all these different substances on there.
And
if they mix, and if they mix together, you don't know what in the heck you have on.
They store just enough of them that they're under the DOT reg.
Correct.
Yep.
And so when they may be 2 ounces under, but they're just enough under that when they ship them, and if they turn over and turns into a fire, man, it's bad.
Like you said, if somebody's transporting a big container of X substance, you can look. There's a nice little placard on there, 1405 or whatever it is. It's going to tell you exactly what that is and how to treat it. But if everything's mixed together, you don't know what you have. Maybe something way worse. So.
One more thing I almost forgot is that we've seen here in the last few years with disasters or power failures, going into the winter season with potential people losing power from an ice storm or whatever. But, hurricanes, tornadoes, anything where people are using generators, leaving the generator in their house.
Yep.
That's
in the house.
Even in the garage. The garage door's open. I get generators in there. I get it. You don't want the generator stolen. I'm with you. I'm on the same track. But if it's in the garage, it's attached to the house.
Every time you open that back door, you're letting high concentrations in. And
so I don't know if anybody cares about medical history. I think medical history is really interesting. I'm such a nerd. Brad, you mentioned the 5 parts per million, the 5% kind of stuff. Do you know where those numbers come from? So the guy that did the experiment, this is super sketchy, and nobody would ever be allowed to do this today. But the way that they found what levels have toxicities is this guy took a bunch of stray dogs, taped a hose to the back of a truck, like the back of a vehicle, and he just funneled car exhaust in, and he would measure what parts per million started causing like cardiac toxicity and respiratory toxicity and neurotoxicity.
Never would allow that today.
And he would just measure. He just killed a bunch of dogs, just putting a bunch of car exhaust into them, just seeing how much it took to kill the dog.
No, I did not know that.
Yep.
So moving on,
there was duct tape involved.
Oh, yeah.
Duct tape and a little
bizarre,
little weird pipe.
Man, moving on. So something else we see a lot in Mississippi, rural area, farming communities. My family, a lot of it in the Delta, organophosphates. So it's a wonderful test question that they love to give. I think every level of medicine, whether it's your EMR all the way through Peds and everybody else, organophosphates, we see them a lot. Pretty good bit. It's harvest season around here, but.
Which one did y'all do? Did y'all do dumbbells or sludge?
Sludge
bees.
Yeah. And you know what he, like he said, is on every exam.
It is.
When I got out of paramedic school, I was expecting I was going to see this like all the time.
Yeah.
You know what I mean? Because it was drilled into a sludge, and I don't know. I've never seen it personally.
Well, I have. It just depends on. It depends on what part of the country you're in. Like if you're in South Texas, where they just got fields and fields and fields with migrant workers, and the fields are too big to pesticide any other way other than a flyover. You see it, like you still see some like private families that have larger farms use organophosphates as pesticides. You don't see it as much as you used to, but we definitely still see it. There was a pediatric patient out in the state earlier last month that co-ingested hydrocarbon and organophosphate and ended up succumbing and did not make it. But it was another one of those. And so rural families, farms, you still see it a good bit. Migrant farms, you still see it a good bit. Large scale farming organizations where they're still doing flyovers. You see a good bit. It's another decon one, right? Like if you got sprayed with organophosphate, God, you gotta get that crap off of them. What that's
the minimum shower time, if I remember right, is 30 minutes.
Yeah, it's a 20-30 minute shower, and you don't go in there with them. They just stand there. Some places, and you mentioned earlier about environmental stuff. Like some places don't. Those showers in the ER decon rooms are not always heated. So taking a 30-minute cold shower, just sounds like a bad day.
It's miserable already.
It's already a bad thing. The good thing at the Children's Hospital where I did fellowship, they actually had heated decon showers.
They got the heated floor too?
No. If you fell down on the floor, it was like ice. But they are bad deal. Sludge bees is my favorite. Some people like dumbbells. I didn't like dumbbells because you forget that there's more than one bee.
Yeah.
But I think that's always a big one.
When you see sludge, it's not a lot of people think, oh, I may see all of it at once. Sometimes you may have one or two symptoms manifest at a time, and then now if you let it progress all the way through, it's a true progression, and it's every orifice they have liquid coming from it.
Yeah.
So when you start seeing one or two, it's one of those. I don't know exactly what poison control is going to tell you to monitor how long, but if they ingest it or are exposed to it, minimum 6 hours. Or don't dismiss it. Hey, this is one of those patients you want to watch for a long time, or make sure that, hey, this is not progressing. It's not something, even as a parent, hey, all right, we're going to watch her get a night.
Yeah, it's complicated actually. So the overwhelming majority of patients are going to be symptomatic within 3 hours. So a 6-hour watch is the minimum that poison control is usually going to recommend. But there are known organophosphates that are used in like various and sundry farming, agrarian kind of rules that they actually are known to not present for 15 hours and 30 hours. So trying to get to the bottom of what it was is really, really helpful for your poison control call. Like, we're talking kids here. So dad's going to come flying in the door with the child to your local ER, and he may not have brought anything with him. So, that's what cell phones, God made cell phones for a reason. Like call somebody at the house or your neighbor or somebody to go and get the name of the product.
Take a picture of it.
Don't bring it on the way out.
Don't bring it.
Whatever you got. Don't bring it here.
Don't bring it.
Don't bring it.
Don't bring it into the ER, but take a picture of it because it matters. Most of them are going to present really rapidly, but they're not necessarily. And for those who don't remember, just in case, sludge bees, right? Salivation, lacrimation, urination, defecation, gastric emesis, and then the B's is bronchospasm, bronchorrhea, and bradycardia. So they don't all present at once, but any one of them is enough that you should be worried about toxicity. And this is something that we kind of teach a lot to the trainees is just because they're not bradycardic or, having wheezing does not mean that they're fine. If they are drooling and they're crying, you need to assume bad things. And when you make that phone call to poison control, they are not asymptomatic. They are symptomatic from their organophosphate ingestion, and you need to go from there. But the other thing we always remember is the sludge bee stuff, that's only half of it, right? That's only the muscarinic part.
Yep.
So all of these are muscarinic and nicotinic processes. And so these are true cholinergics. And so they affect both sides of that fence. And so watching for fasciculations, watching for neuromuscular changes, watching for seizures, watching for CNS depression is really important too. Because if you're having those things, and all you have in your ER is atropine, they got to go somewhere else.
Yeah, and you probably don't. You probably don't have enough atropine.
You probably don't.
That's what I was going to ask. I mean, we carry 2 PAM on the aircraft.
Oh, good.
And I know we have it here at the medical center.
Yeah.
Are rural ERs?
Depends. It depends totally on the ER. Depends totally on the size and what have you.
Praladoxime is expensive to keep, and it expires. And
the good news is, I think their expiration date on ours are 7 years.
Yeah.
Yeah.
And the only way it should ever be given is in 2 PAM. And so you're not just buying praladoxime to kind of keep for any other purpose. Like the only thing that we use oximes for is this, and it always has to be given with atropine. And so you have to buy basically a specific product. And so if you only see, like you said, you've been doing this for a long time and you've personally not seen one. So a lot of places just don't see the point in carrying it. And ultimately, they're probably not wrong, because as long as they don't have nicotinic symptoms, like the pralidoxime doesn't do jack squat.
Right.
But for those who it does,
It's a literally make it or break it life-saving drug.
yeah, it's a game changer.
So for dosing, just to kind of touch on that, 0.05 per
for
kilo
kids,
with atropine.
It's a really important thing to remember, because everybody knows atropine from a code dose is 0.02, right? That is not the right dose. You're given a lot more. It's 0.05 mg per kg per dose, and you double it every 5 minutes.
Right.
And you just keep going.
Until you get improvement in the symptoms.
Yeah, like you give it until they stop their respiratory stuff is usually the way they go. So I wouldn't just out and out jump in and give atropine to a kid who's drooling, but I sure wouldn't send him home. But if he is having respiratory symptoms, if he is coughing and just having fluid from his lungs, and he is wheezing, and he is experiencing respiratory stress, you keep giving atropine until he gets better. Because this is one of the weird things, because it's specifically a muscarinic problem, the atropine will fix their wheezing.
It competes, right?
Yeah,
it competes
it's directly
with
addressing.
acetylcholine.
It's going in there and forcibly kind of kicking things off with the acetylcholinesterase inhibitor, and so it's freeing up the neuromuscular junction to function again, and you can give huge amounts.
So when you think about atropine, most people think of it in code dose, right? So we're talking about 1 milligram is 10 cc's.
Right, for an adult or adolescent.
And we're talking about the dose, you're talking about doubling it.
Yeah.
We carry the 8 milligrams and 20 cc's on the airframe purely for this reason, along with the 2-PAM. When you start dealing with giving multiple doses, everybody has their own street version of how they do this. If I've given, whether it's adult or pediatric, I've given more than 4 doses, they're on an infusion.
Oh yeah,
that's my personal. And after they've gotten 2, I'm mixing the infusion. It's just here, let's have this in the background. As far as the infusion goes, a lot of people are, I'm just going to titrate to effect. This is one of those you truly have to just titrate to effect.
Yeah.
Figure out the math on the back end of what your dose would be every 5 minutes. And then start there, and then just titrate up.
Yeah, and you're not worried about the you're always worried about tachycardia, but tachycardia is not the goal. So like when you're giving atropine in codes, like you're giving it to fix bradycardia, right? And bradycardia is one of their symptoms, but you don't stop at I fix the bradycardia. You are focusing on the respiratory thing. Almost always is respiratory that kills these patients.
Because their heart rate will normalize before their respiratory symptoms.
Yes.
And you also don't know why they're tachycardic.
Right.
Like, honestly, you don't know.
Well, they just got stuck with IVs.
They've been
also
pouring fluids out of every orifice in their body. Their insensible losses are super, super high. They get dehydrated hella fast. So, you're talking about patients who are at baseline, probably some essence of dehydration.
Which is another next point I was going to bring. I'm glad you even said it. The next point a lot of people forget with atropine, whether you're giving it in a code or what have you, is it does dry you up.
It does.
So make sure they get a bolus concomitant with it. Not necessarily, you don't have to slam them with it. You got to give them 20 cc's per kilo or 10 cc's per kilo or whatever it is. You don't have to slam it with it right away, but make sure they have maintenance in the background, A, for the sugar, but B, they're having maintenance plus a little fluid, so you're getting that volume back from those insensible losses. Especially in pediatrics, they're going to be upset. I mean, they're getting all this stuff done. They're in a weird environment. They probably have people hovering over them.
Oh, yeah.
So keep that in mind, that they're going to need some extra fluid on top of everything else to catch up with those insensible losses.
And for the protopam, what's your recommendation on weight base for that?
So I think it's 0.75 milligrams per kilogram, I think is the dose for pralidoxime.
Okay.
Pulled that out of my pocket. That was crazy. I feel good about that.
I know adults are 1 to 2, but I always have to look at it.
Adults you give about 2 milligrams. Kids it's 0.75 up to 1 milligram for the first dose. And usually you don't ever give more than 2 for pralidoxime. And that's mostly because the nicotinic stuff should get fixed pretty easily with the oximes, but again, it's not what's ultimately going to kill them. And so there are recommendations on oxime infusions and things of that nature, but from a pre-hospital community care standpoint, you give 2 doses and you're done. And then get them to their most the closest quaternary or tertiary care center and let them do that kind of stuff. I wouldn't worry about it in a helicopter. I wouldn't worry about any of that stuff. If they're seizing, give them benzos.
So let's talk about the nicotinic stuff. So there's been some weird things, especially with the organophosphates, because nothing is easy, right?
Of course not.
When we start talking about the nicotinic stuff and seizures, there's a lot of people that are concerned, or they're misinformed that there's going to be full tonic clonic. They're going to seize their tail off. It's like some neurogenic subrac or what have you. A lot of times it manifests more like eclampsia. It's more of the skeletal muscles. It's more of the focal seizures, that kind of stuff first. So those subtle assessments, the reassessments on your patients to figure out, hey, has this progressed to a nicotinic state and you do need the 2-PAM? Those are some important things to pay attention to, especially in kids, lip smacking, the focal seizures with their hands or legs and stuff like that.
Yeah, it's always important to kind of differentiate between seizure and fasciculations, right? Because you can be nicotinic and not be having a seizure. But those small motions like you're talking about, you'll see their thighs quiver or their forearms quiver. Always check their tongue. I know that's always weird, but like you'll see these crazy, especially for ingestions, you'll see that their tongue fasciculates. And, you know, we tease a lot about people's physical exam skills these days, but like just having them open their mouth, stick your tongue out. If you stick their tongue out and their tongue is like doing this weird, creepy dance, like makes you want to get your phone out and take a video of it, they're having a nicotinic reaction. And yeah, sometimes they do go on to full-blown tonic-clonic seizures, but a lot of times they don't. But that's still an indication that they need pralidoxine. And so I just tell people CNS depression is can be from either one, but it is to me a reason to give pralidoxine because we know that the acetylcholinesterase neuromuscular junctions, those are all up in the brain too. And so like you need to kind of address those. So CNS depression is one of my indications. If you ever see a muscle twitch though, assume that they have nicotinic stuff and just give them a dose of pralidoxine. And if they have a seizure, give them benzos. Even though this is related probably to one of the two pathways, benzos. It's just easier to kind of get it out of the way. Same thing with like airway control. You're probably going to want to control this airway pretty early.
Yep.
But any of these patients with CNS depression or respiratory depression, like you got to be worried about more than one pathway from the organophosphate.
And again, one thing, just to kind of throw props out to the poison control, Mississippi Poison Control, 1-800-222-1222. Call Medcom 984-4EMS. Call early, even if it turns out to be nothing, no harm, no foul, but to give you guys a heads up as quickly as they can.
And it helps everybody out there. First off, and I don't know if I'm allowed to say this, but I'm going to say it anyway. Every single time you call poison control to report a poisoning, it goes in a database, and at the end of every year, they look at that database and see how many times are people calling, and that's how they get funded. So if nobody's calling, nobody's funding, and nobody's going to be on the other end of that phone call when you make that phone call. So every poisoning, every ingestion, every medical thing should always be reported anyway. And the other side of that is, like you said, Will, toxicology can get complicated. I love toxicology. I think it's super fascinating, and I have like 3 textbooks on it, and my fellows make fun of me all the time because my favorite of my textbooks are my tox books. But that's not everybody. And it shouldn't be everybody, and you got a lot of other things to worry about when you're taking care of patients in the back of Podunk, Mississippi, or in the back of an ambulance. Like, you don't have time to do all that stuff. So that's what those people are there for. So like, you can call and you can talk to a poison control specialist, and they will pull stuff out of databases that they have access to and give you everything that you need to know. And if it does get too complicated, you just ask to talk to the toxicologist. Our docs here at UMC cover the toxicology phone. You'll get a resident doctor first for the most part, and then you'll get an attending doctor who has done a toxicology fellowship and is toxicology trained, and they will give you all sorts of good information. And if you don't know the dose of pralidoxine, they can tell you the dose of pralidoxine.
Absolutely.
And so we call poison control all the time, and we are the tertiary quaternary center in Mississippi, and we call it all the time. I don't always call to get advice, But I call to tell them, hey, I got a kid here who's
Sure.
ingested this thing, and we need to report it so that it can get watched. And the cool thing is they follow up. So if you call from your ER and say, I've got a kid who ingested, Drano, and we sent him to UMC and he got better, and so they sent him home, they will call UMC to find out how the kid's doing, and they'll also call the family at home like in a few days and see how the kid's doing.
Mhm.
So they're like, it's a built-in like home check. So it's a pretty cool system, and I definitely, you're right, Paul. Like,
It's
glad
a
you
great
said
it's
it.
a great
It's
resource.
such a good resource.
Guys, anything else on environmental stuff, or we move on to fun things like?
Let's see, anything on there?
Maybe a little bit on acid bases. I think a lot of people think, oh, it's acids. What if it's a pool and it's muriatic acid or whatever.
Yeah.
But basic substances are
Bases are worse than
so
acids.
much worse.
Bases are always worse than acid.
And if you look at the literature, it uses terms like liquefaction of tissues
Liquefaction
between
necrosis.
9.5 and 12 pH, and you think about what that actually means. You're literally turning tissue into liquid in seconds. So if you think about it, bases are way worse than acids, regardless of what the substance is. Just as a whole, bases are way worse.
In general, the kind of things that I focus on when I talk to people about acid-based stuff, yes, bases are always worse. Like, I care way more that you ingested oven cleaner than that you spilled a little bit of, the silver acid that you kind of use to clean your jewelry on. But there are kind of a few things to always talk about that aren't that big of a deal. Like, we see kids transferred all the time for a base caustic substance exposure, and it turns out it's just household bleach. Household bleach is not sodium hydroxide, it's sodium hypochlorite. It has a pH just a little bit higher than 7. It's really honestly not that, and it's usually like 2% or something like that.
It's super non-concentrated.
So you could drink the entire bottle of bleach at your house, and other than feeling like just garbage and puking your guts up for a little while, you're really honestly not going to get that sick from it. It's not going to do that bad. It's definitely not going to burn your esophagus or your stomach or your intestines. So watching the nausea and watching for aspiration is important, because chemical pneumonitis can happen from stomach acid. It's not even necessarily from the bleach itself. So paying attention to that. But it does affect your eyes. Your eyes don't tolerate too much of anything getting into them. So I always, whenever we talk about acid base, I always want to talk about eye stuff. Flush the piss out of these things. Anything acid base of any kind, it doesn't matter how big or how strong it is, you just start flushing. And we do a liter per eye, period. Everything. It doesn't matter if it's like close to normal or not. So you just go in. If you have pH strips, awesome. That's like the favorite. Use a pH strip, test their eye, find out what your starting point is, and dump a liter on both sides. We do some MacGyver stuff sometimes with this. Like, you can take oxygen tubing and put one nasal cannula on one side of the, one into one tear duct and the other into the other, just right across the bridge of the nose, and basically hook up IV tubing to the back end of the oxygen tubing and just like use it to dump fluids through. Or you can literally just have somebody help hold this person down, and you just pop that bag and just like start dumping saline or water into each eye. And every single time you finish a liter, do another paper strip. If you don't have pH paper, you probably should do it for pain and then transfer them somewhere else. Like, never assume that because their eye stopped hurting that they're done. They need to get somewhere where they can get tested, because a lot of times, A, kids lie to you, and B, again, just because the pain has necessarily gone doesn't mean that they are back to a pH of 7. They can still be a pH of 8.5 and not have that bad pain after 3 liters of fluid have been dumped on their face.
I'm glad you brought that up, because most people don't, as far as what you can use. I think most of us were taught in EMS starting out, you always use oxygen tubing because it's the only thing you have available.
It's easy.
But if you do have a Morgan lens, that's great. They work awesome. They're fantastic if the patient will tolerate it.
They are uncomfortable as a mother.
And 2, it's a kid, so trying to get it in a kid. I've done it I know, Paul, know you've done it too, and it's very painful to watch
Yeah.
and very painful.
They're
to facilitate.
huge.
So
And I'll also say this: every time you change out a bag, please put more from a personal experience. Put more lidocaine,
Yeah.
tetracaine
Yeah.
through the actual Morgan lens. Every time you swap fluids, you should add more tetracaine.
don't use cardiac lidocaine for the record.
No, do not use cardiac.
Yeah, don't
Make sure
cardiac
you're using
lidocaine on their
appropriate
face.
ophthalmic drops, not anything redneck there, but definitely tetracaine's a
Love it. It does remove the ability to use pain as a guideline for you. So if you don't have pH paper and you're using tetracaine, you need to be planning to transfer them while
Yes,
you're dumping
100%.
fluid on their face, and not stop until you transfer them. Because you don't have anything else anymore at that point to kind of measure stuff.
Coming back to acids and bases real fast, if you know what the substance is, again, really important. Also, it'll help you with, as far as deconning them or anything else, you can use those ERG books or anything, or poison control that can tell you if they do have a really caustic base powder or solid that's on the patient, make sure you don't use an acid or something to get it off.
So you should, I would just argue most of what we teach in toxicology is you should never attempt anything other than neutral water to decon acids and bases. We still see people all the time like, oh, I'm going to neutralize the base, I'm going to put baking soda on it. Or, oh, I'm going to, whatever. Though every time you neutralize an acid with a base or a base with an acid, you create heat.
Yes,
It's a chemical
It is
reaction.
always a productive reaction. So it is thermogenic. And so you are going to burn somebody.
and I think it's good if it's something, to your point of powder, if it's something that you can dust off, whatever you can dust off first,
Yeah.
try to get some off without making the situation
Not
worse.
with your bare hand.
Not with your bare hands. Well, I mean, we both know folks that have done organophosphate poisoning to themselves because they didn't wear gloves when mixing things. But
And when
same
you
thing
say-
with powder.
And I'm glad you brought up neutral water as well. Make sure you understand where the water's coming from.
Yeah.
So if it's coming out of a creek, what's in the creek?
Only
If all those
Jesus
kinds of, or it's coming out, even city water. If that may have something in it or some kind of chemical that's chlorine or what have you in there.
Water out of a fire truck is not the
Not
cleanest.
always. So, not saying everybody rush out to Walmart or Kmart or Target or any of those and get a whole bunch of distilled water, but that's what you want. So,
Yeah.
Moving on down to medication-induced tox. Okay, y'all good?
Yeah.
Okay. When we talk about medication-induced tox, the first thing I wrote in here on this outline was grandparent Skittles. It's for a reason. There's Skittle parties a lot of teenagers used to do all the time. They dump a bunch of pills in there, see what kind of reaction we can get out of it.
Taste the rainbow.
Yeah. Medication-induced, a lot of them are truly polypharmacy. There's not, sometimes every once in a while, a kid, for example, will get into a certain pill bottle jar, something was left out, or may only be Tylenol or Claritin or whatever it is. But a lot of times these are true polypharmacy cases. So understanding what they're involved in or what they're not, but also treating them symptomatically based off of what it is. When y'all think of all the grandparent stuff that kids get into, first thing that bothers me the most is probably blood thinners is one of them. And then the next stuff is all the cardiac jazz, all the calcium channel blockers, beta blockers, anything else. Talking about blood thinners, have y'all seen that before? Does that bother you when you think of those, like the Xareltos, the 10As, the Coumadins, or all that kind of stuff?
First thing that comes to my mind that's hugely concerning to me, both of my grandparents growing up, I could remember them talking about like it was the neatest thing that, they now have an extended release this and extended release that. And I think especially in the pediatric population, but just in general, all these extended release medicines, okay, well, that's awesome. It's great for the person taking it, but for the accidental ingestions, for the whatever it is, half a million kids are exposed to it, every year, whatever it is, that extended release, they look normal at first presentation or even at an hour or 2 hours. And, to your point with the calcium channel blockers, it might be 6, 12, 24 hours later when that extended release fully starts kicking their tail. And whether it's, coags or whatever it is, just extended release medicines in general kind of give me chest pain with all these ingestions. Just, I think people tend to, like we mentioned earlier, poison control, having to tell people, hey, you need to watch them for at least 6 hours. These extended release could be a 12 or 24-hour later thing.
Yeah, I mean, extended release is most every time we're going to recommend admission. And honestly, sometimes we're going to recommend a long admission.
Yeah.
People don't think about, Haldol has a 72-hour half-life. So for sure, extended release can be real complicated. They add an interesting layer to a lot of the conversation with regards to tox. But yeah, there's never a circumstance where I've really seen any sort of toxic drug that has an extended release product that should ever go home. Pretty much is not going to be recommended. Blood thinners, when you brought that up, it's kind of weird. I've seen a lot of warfarin overdoses, and for the most part, I think I've only ever given somebody to reverse a blood thinner once. Usually, as long as there's not really a trauma, and as long as they're not like bleeding from their gums or, their eyes or something like that, we try not to give them additional medicines to kind of muddy things up. Because, sometimes giving people protamine and giving people a bunch of other stuff gets complicated. Warfarin's kind of a different creature, because giving somebody IV vitamin K is not that big of a deal. But even then, we don't recommend it very often. So a lot of these kids, what we do is we watch them. We get coags. Depending on the half-life of the drug, we may get a coag and admit them, or may get a coag and tell them they need to go back and see their doc in 2 days and get another set of coags. Like most relatively minor warfarin ingestions, I'm going to get a coag today just because, honestly, we know that it takes 48 hours for an INR to really change from warfarin anyway. And then I'm going to go tell them to go see somebody in a couple days and eat some leafy green vegetables in between. But like most of them, unless they are actively bleeding, most of the time I don't think I've ever reversed anything or been told to reverse something.
The ones that scare me are that, I'm glad you brought it up, is how long is the onset of the drug? So if they got, I'm throwing out numbers here, but if they took 10 of grandma's Coumadin pills,
yeah,
and then they don't have something, and then 4 days later, now they're bleeding out because they fell down, and now we have this weird picture of they're bleeding from every orifice and this, that, and the other. It's the not following up and realizing, hey, some of those medicines take, for truly the liver to start playing with it, it takes 2 or 3 days.
Yeah.
So what happened 2 or 3 days ago? So you have this trauma picture, but then you have this trauma picture that doesn't make any sense, and it's really a tox thing.
Yeah.
On top of it, that's purely out of an experience I had. Myself. But most of the time they don't have to be reversed. But it's one of those things. If you get something that's weird, a weird PT that's way out.
Yeah.
Then, hey, well they take medicines every day, or what? Who lives in the house? Well, somebody's on Eliquis.
Yeah.
All right. Well, have you been taking some of the Eliquis and thinking it was nighttime gummies and it's not? Those kind of questions that come to mind.
Skittle parties are definitely a scary thing for us for a bunch of different of these meds. We see a lot of people. For me, as a kid doctor, I worry a lot about the antitachycardics, so like betas and calciums, but one of the things we get into a lot with these kids is grandma's diabetic medication. Metformin's fine. Like, honestly, metformin doesn't do too much to you. If that's all they're taking, then I don't even care. They deserve the headache they get and the bellyache they get. But if they're taking glyburide and glipizide and all those things, like, those kids can get pretty sick from it. And the scary thing to me is always the doc that, like, takes one of those kids, gets a glucose a few hours later, and it looks fine, and so they think that it's fine to send them home. Those glipizide type medicines, those are like, they don't cause hypoglycemia for like 12 hours. So most of the time we admit these kids, and sometimes you see their glucose just tank a day in, and all of a sudden their glucose is 35 and they're like barely responsive. And so, those ones we take real seriously. Any of those medicines, sulfonylureas get all of these we get admitted. Any diabetic medication except for metformin, we're pretty much going to bring in. The betas and the calcium scare me. They're still ones. They are in the one pill can kill category when we talk about medication tox in kids. A single adult dose in a child under 10, 20 kilos can be fatal. And so those are the ones that scare me the most. Grandma dropped one calcium channel blocker pill on the floor. Yep. And the 7-month-old's crawling around and picks the thing up and puts it in their mouth, and they're in the news the next day. So those ones are pretty scary. Calcium channel blockers and beta blockers are really big deals. So I wanted to talk about them for a minute, if that's okay with everybody.
Yeah.
Oh, yeah.
Only thing I was going to add on the coag stuff is I have seen a few tox kids, and it was rat poison.
Mm-hmm.
And it wasn't anything obviously like we talked about reversible, but they were like, well, I don't know that I didn't see any medications, and you get their coags back and their coags are out. It's like, is there anything in the garage? And open trays of rat poison in the garage, and they just didn't think about that as a medication,
right?
And they didn't think that's
warfarin. That's warfarin.
Straight Coumadin.
As far as, let's do betas first.
Yeah. So the cool thing is, for me, for the most part, you can, relatively speaking, kind of imagine them in the same general category as far as management goes, with a couple of different exceptions. Because unfortunately, a lot of times, especially if they're coming from a Skittle party, you have no effing clue. Like, what color was it? I don't even know. I put 17 of them in my mouth. Mm-hmm. So betas don't really. Betas are going to cause potentially some hypoglycemia, which is the big kind of red flag for them.
Yep.
And so if you've got a patient, the scary thing is if they took a lot of this looks a heck of a lot like an opioid ingestion, right? So they're going to be bradycardic, they're going to have respiratory depression, they're going to have CNS depression, they're going to be hypotensive, but they're going to be hypoglycemic. And so that's like a big tipping point for us. You should always worry about alcohol in a teenager because that'll look a lot the same and they'll be hypoglycemic as well. But these are kids that are going to be really profoundly bradycardic and really profoundly hypertensive if they had any substantial ingestion. Calcium salts, so ABCs for everybody, right? So
always
every single medication that's on this list, and it's one of the reasons why I say tox is really hard and tox is really easy, because you just do the same thing for everything. So if they have respiratory depression, CNS depression, you don't have an intact airway if the patient's GCS sucks. Right, so intubate these patients. It is honestly somewhat helpful for especially bad calciums to just intubate them early if they have really bad respiratory and brain CNS depression, because it removes one of the biggest barriers to effective treatment. But getting their airway under control, making sure you try to get an IV access, get some fluids going on board, but then calcium salts, huge deal. To kind of help with some of this. HIE can be really helpful. Mm-hmm. We talk about hyperinsulinemia, euglycemia therapy, giving them a dose of insulin followed by like a slug of D10 or D25 can be really, really helpful. And then early EKGs and serial EKGs on these patients. Like if you suspect even the slightest bit of concern that this kid got into one of these channel blockade drugs, really quickly getting them that first EKG, seeing where you are, and keep going back to it, because it's amazing sometimes how rapidly their QTC just like stretches out, and at some point it's going to stretch out enough that they're going to go into a bad rhythm, and then you're in trouble.
So in talking about insulin, is your recommendation basically like double what like a DKA rate would be on an insulin infusion for high dose toxicology?
Usually we give pulse doses, honestly. So a lot of times what I'm going to do is I'm going to hit them with calcium gluconate first. I'm going to give them 100 grams per kilo or milligrams per kilo of calcium gluconate as a first right out the gate drug. It's cardioprotective. It helps some, replaces some of the lost kind of electrolytes, but it stabilizes the cardiac tissue. So it helps me in anything else I do. And then if we're talking like adolescents or bigger people, I'm going to give 10 units of insulin followed by some dextrose. And I'm going to watch and see what happens. And then 30 minutes later, I'm going to do it again. You're never using anything long acting. You're always using log, and you're not injecting skin. You're always giving it through the IV. You're just trying to get you're just trying to get them fixed. Excuse me. And you do it short acting, watch, and do it again. Eventually, they'll go hypoglycemic if they're not already hypoglycemic from the beta blocker. And so that's why you're always following it with dextrose. You're always following it with dextrose.
A lot of people, when they start talking about kids using the HIE, so I think the smallest I've ever been a part of was an 18-month-old, and we were using the 0.1 units per kilo.
Yeah. And that's right for small bodies.
For push dose as far of it, and then honestly, if you don't have D10 in the room, you'll go find some.
Sure, yeah. You can make D10. Like
Make
if you're an adult center that doesn't ever carry D10, because a lot of places don't, get your D50 and then just dilute it down to D10. It doesn't take much. And honestly, even for very, very young pediatric patients, yes, high dextrose containing fluids is bad for their veins, but we use D25 all the time in little kids. And so you just take your D10 or your D50, you figure out whatever their kilogram dose is. And so if they weigh 5 kilos, it's 5 mLs of D50. And then you just put 5 more mLs of water in there. And then you got D25. And that's fine. You can push that junk.
As far as
I was going to say, what are your thoughts on where glucagon fits into?
Oh, so that's real controversial. I know that's such a nerdy thing to say. Glucagon is really controversial. So glucagon has not been found in almost any major study to actually fix this truly. It has been touted in the past as a good antidote for beta blockers. It does not seem to have held up as well as it seems, but it's not unsafe. So honestly, like if you
specifically for kids you're talking about, or
period,
adults also?
period. If you look in much of the newer literature, the effectiveness of glucagon at reversal of betas and calciums is really actually not good. It didn't really hold up in repeated study, but at the same time, it is not an unsafe product. It's really not bad, and so it's still, for at least betas, it's still on the list. It's still, if you go to critical care medicine's kind of guidelines for antihypertensive overdoses or toxicities, it's still something that you give. It may not do anything, it might, but it's not going to hurt anybody.
the trick with glucagon to me, there's a couple of side effects to it that are challenging. Again, I'm gonna give it. If it's beta, I'm gonna try it. Why not?
It's fine.
Dosing in adults is 5 milligrams. That's 5 vials. So from a cost standpoint,
That's fair.
it's usually somewhere between $100 and $200 a vial. So you may not have it on an ambulance, or you may not have it in your ER. You may not have enough to actually truly be effective.
To do anything.
It does work somewhat to mitigate the effects and everything I've read, but it's only temporizing. It's not gonna like get you out of the jam. It's not a true antidote. It doesn't fix it long period over time. So it's one of those drugs where, okay, great, this may bail me out of a jam. It's kind of like albuterol and hyper-K, kind of way I think of it. The trick with it to me is glucagon we use a lot of times for its other effects of smooth muscle relaxation. Well, if I'm worried about a cardiac protective patient that I don't want everything to go dilate, I want to increase their contractility because they are in beta blockade. Do I really want to dilate their smooth muscle at the same time? That's a question.
Yeah.
And then you worry about the airway side of that as well.
Yeah. It can kind of create some issues, but it's overall not terrible. These are people that are going to be resistant to atropine under most circumstances if these are really substantial ingestions, but that doesn't mean don't try it. It just means it's probably not going to work. A lot of times people end up on infusions to kind of help this, but my big dig on all of these, and this is true for both betas and calciums, if you had to intubate the patient, honestly, I go directly to transcutaneous pacing. Like if the patient was already so out of it that you had to put an airway in, the biggest barrier to transcutaneous pacing is pain and the need to sedate them. And you always kind of worry a little bit in somebody who's hypotensive and bradycardic to put them through the sedation process, because we know intubating hypotensive patients is one of the worst things you can do. Plug always epi before you intubate a hypotensive patient. Spritzer if you want, or the full Monty if you've got it.
What about vasopressor support? Which
So vasopressin and beta blockade is
no, vasopressors like
just pure.
Epior.
Yeah,
I
pure.
know
Yeah, if they're
vasopressin
awake,
and
if they're
dopamine.
awake,
Yeah,
if they're awake, I do epi pretty early, and then you get it to a reasonable dose, and then you add norepi if you need to. The norepi is really just about blood pressure support. It's not going to do jack to the heart, but that's why I start with epi.
Yep.
If they're awake, I give them atropine and calcium salts and potentially some insulin and dextrose, and then I move pretty quickly if they're not looking good to epi infusion. I don't give them push doses of epi. You should have time to mix an epi bag, even if it's just you're mixing a dirty epi bag, but you should have time to mix epi. And so, yeah, I go on to epi infusion pretty early. It's really just about getting that heart rate back up, because their blood pressure is almost always purely related to cardiac output.
Yep.
Real fast, you mentioned transcutaneous pacing. A couple things I want to bring up with that. One, if you're going to pace somebody, personal pet peeve of mine, make sure you put the pads in the right spot. Kids, it's real easy. Kids, it's super easy because they're usually small enough. You only had to put it on the back and the front.
That's right.
For adults or bigger kids, a lot of times we want to put them and it goes right through.
It should
one
be in the
anterior
same
and
spot
lateral.
for coding.
As far as pacing them, if they're a bigger kid, it's sometimes a lot easier to put front and back.
That's true.
Gets you a little bit better electrical activity, gets everything working a little better. As far as some of these kids, it's not uncommon for kids or adults, if they're in a beta blocker overdose, you transcutaneous pace them for a minute. Eventually you're gonna have to keep on going up. Transvenous is a thing. They may go to the cath lab. They may think about considering taking them to a place a place that could float a transvenous pacer or temporizing pacer to get them through this process.
I actually love transvenous pacing for adolescents, adults. It's way more complicated in little kids. But yeah, the issue is always if you're at a center that's really comfortable with transvenous pacing, you're also probably at a center that has cardiology.
Mm-hmm.
Yes,
and a cath lab
that doesn't want you to
and a cath lab.
I remember distinctly, I had a guy, he was 80 years old. He had overdosed his own beta blockers or calcium channel blockers. I think it was beta blockers. And he was bradycardic as a mother, and was like losing his mental status. And so we had called the cardiologist, and I was already putting a central line. I had intentionally gone to the IJ. I had intentionally put the transcutaneous or the transvenous pacing central line in so that I could float the wires. Mm-hmm. And the attending got the cardiologist on the phone. He's like, "I'm on my way in. Don't do it. Just take him to the cath lab." And so if the patient is not like dead, the cardiologist probably wants to do that themselves in the cath lab. So, they're probably going to want to do that. And if they are dead, again, throwing them on transcutaneous pacing temporizes things until the cardiologist gets there. That being said, if you're out in a community setting and you don't have a cardiologist, you can come in and you are personally quite comfortable with placing the transcutaneous pacing central line in the IJ and feel very good about your ability to float that wire down into the right atrium. Like, honestly, it's better for them in the long run than transvenous or transcutaneous stuff. So I have no issue with it. But it's definitely one of those things. The barrier is the awake patient. And so if they're awake, then you're going to have an issue.
It's a challenge.
It is a challenge. And so unfortunately, a lot of times in pediatric hospitals, you do stuff until the patient becomes non-responsive, and then you transcutaneously pace them. Problem is then they wake up.
Yeah.
And now you've got an awake patient getting transcutaneously paced. At that point, it's fine. At that point, you
and they're not happy about it.
Yeah, they're getting pissed. I've never personally been transcutaneous paced, but I've heard stories and I've seen patients, and it doesn't seem like it's a fun experience. It's not the same as getting defibrillated. It's a lot lower volume.
How was cardioversion, Brad?
I don't remember. They did a good job.
I don't remember. But we do usually at that point put them on sedation drugs. And in a lot of institutions, the standard is going to be to just go ahead and electively intubate once you get their heart rate and blood pressure back under control. And then you just kind of wait the process out. But those are beta blockers. The good thing is, in general, my personal experience has been that you don't get the really bad ones as much with beta blockade. Calcium's different. Calcium can be an absolute crapshoot pretty quickly. I've seen people have to get rescued with lipids for verapamil, and things like that. So calcium channel blockers are pretty bad because they don't tend to respond to any of those things. The one good thing about calcium channel blockers is they tend to be hyperglycemic. And so they actually, and their hyperglycemia is resistant to insulin. So you can give them insulin and you don't have to give like huge doses of dextrose as you're going through that process.
That's something, matter of fact, we had our toxicologist, Brett Marlin, came in and taught a lecture yesterday for us, and that was one of the things he mentioned with calcium channel blocker overdoses was the hyperglycemia, not having to worry about monitoring the glucose as closely as you would with a beta blocker overdose.
It tends to be a lot better, which in theory is a good thing because it means you can actually give them a lot more insulin. So insulin's a really helpful cardiac promoter in those situations, and so it can be a big deal. I find in these that you have to have them on vasopressors, but they're not going to do jack squat. Because the calcium channel has been blocked. And so it doesn't matter how much epi you give or norepi you give, you're not going to get that back until that process is reversed. And it takes a long time. Most of these drugs have really significant half-lives. And so these are people that are probably going to be sicker, and you are going to probably move to pacing them relatively quickly, but they're also ones who can arrest really fast.
It's one of those patients they're super tricky in transport to me. They're very tenuous. You get them, okay, I get them lined out. I get them kind of sitting there still in a bed. Great. Now they're in an ER bed. Now I got to get them to a definitive center because we're going to try to do CRRT, or we're trying to go to ECMO, or try to get something to get it out of their system, try to dialyze it out depending on what drug it is. But if the second you move them, or the second, for example, you manipulate their vent changes or something that takes off the heart just a little bit, they will crump. And so it's one of those we talk about resuscitating before and intubating all the time, but resuscitate before you move them, even if you're giving them extra stuff. So, hey, they're on an epi infusion. They're going at 2 mics right now. Cool, up at 3. Just give you a little bit extra a little extra buffer before you move somebody or slide somebody around. They're very, very challenging. Talking about pacing a lot here. Just want to quick plug. It's a very challenging process to swap somebody from one pacer to the next. It's something to be done slow. You should start them on. They have them on this pacer. It's working. It's effective. Like checking for electrical and mechanical capture. You'll see us adult patients. We will throw art line at somebody really fast. Even in pediatrics, in this case, I highly recommend an art line if you're capable or have the ability to do it, so you can ensure that mechanical capture and electrical capture are still there all the time. When you're swapping somebody over, they're working great on this pacer, I'm going to the next. Slowly increase your pacer until you get up. Look at what your amperage is. Usually about 1/3 is where I'm on my new pacer. I'm at 1/3 of where I am on my old one. All right, now I can start backing off, and I can start slowly doing this at the same time. It's a simultaneous thing, but trying to maintain the electrical and the mechanical capture. We just said about how the second you manipulate them, these patients are so tenuous, they'll crump on you. Swapping that pacer is one of those crucial moments of is it going to work or not.
It can be a really sketchy thing. I had a friend who was an RT years ago whose kid came in as a calcium channel blocker, and it was a tough experience for everybody. But yeah, these are the ones that you kind of have to keep an eye out for. And fortunately, they tend to lose their mental status a little bit quicker, and so you can potentially move to pacing more quickly, but just keep an eye out. For the ones that are non-dihydropyridines, they are in general pretty lipophilic, and so critical care medicine a few years ago added lipids to the rescue for cardiac arresting calcium channel blockers. Lipids are kind of a controversial subject in toxicology. Some people are absolutely huge fans. Some people are a little bit less so. But they do have kind of limited roles. They're really effective in local anesthetic toxicities. Non-dihydropyridine calcium channel blockers is one where they're a little bit more controversial. But for those lipophilic calcium channel blockers in a patient who's cardiac arresting, they're one of the first things you do because your patient's already dead, right? And so pushing, 1.5 mLs per kg of 20% fat emulsion, pretty rapidly, is something that can be a big game changer for some of those people. Because if they, a lot of calcium channel overdoses that are bad enough that they rapidly progress to cardiac arrest, getting them back can be a challenge.
Challenge.
We'll say that again, a challenge. So a lot of these people just die. So lipid emulsion is something that has kind of been recommended in the past. It's not something that you do easily. It's not something you do necessarily lightly. And it may not, but it's one of those, the patient's going to live or they're going to die based on the choices that you make sometimes. And so why not? So we will call for fat emulsion and push it. And then it's a push dose, and then it's an infusion after that.
And those are typically, when we start talking about this lipid stuff, it's usually not available easily in the ER. And
so it's definitely not going to be sitting in your D-bolt.
Yep.
There are a few exceptions. So if you actually look at Highland, California, for example, they have a really robust nerve block in the ER kind of setup. And so they actually keep lipid emulsion in their ER because of the risk of local anesthetic toxicity and how effective lipids are at reversal of that. You don't keep a ton of it, but you keep enough to at least treat one or two people. And it's just fat, like it looks like milk. And at many centers, you have tons of it because you got patients on TPN and those types of things, parenteral nutrition. So a lot of lipids there, but you got to call.
I know in the military setting, our dosing is very similar to tox for like these medications, because we carry a lot of patients with blocks, nerve blocks, with
I love it.
Patients with amputations and such. So the 1.5, and you can repeat again at 0.75, and then of course the infusion. So
0.25.
you think about that for an adult, you have to carry a liter.
Yeah, it's a lot.
One. Number two, the challenge in a transport setting, like for us to carry it, it has to be climate controlled.
Yeah.
So they all come inside of a wrapper, an external wrapper with a temperature indicator in it. And if it exceeds more than like 85 degrees, that thing pops a dark tar colored, and you're not supposed to administer it. So this is not something that's going to be out in the community transport arena. It's going to be at hospitals and centers.
And again, for these patients, like the patient you're giving lipids to for calcium channel blockers is the one who's arresting. So in theory, if you're doing this right, you should never be driving somebody who started at a place with a pulse and no longer has one. Like, so don't put coding patients in the back of your ambulance. Don't put coding patients in the helicopter ever. This is a conversation I have a lot, it seems like, unfortunately, reminding people you cannot transport that patient. Sometimes I've had to have that conversation with docs that air care is refusing to transport a patient because they know you don't put somebody without a pulse in the back of the helicopter. And the doc will be like hollering, because they want the patient out of there. The patient's going to die if they don't go to, the patient's dead. So like, try to fix the patient, but they're not going to survive in the helicopter any better than they're going to survive on the ground. And so like, you shouldn't have to be doing the push dose for this. You should only ever be doing the infusion part of it. And so the hope is, unless it's winter and you're heating the back of your rig, you really shouldn't deal too much with it overheating. And if you're flying at 10,000 feet, it's not that warm in the helicopter either.
Except for in August in Mississippi.
Except for in August in the summer when the sun's shining right through that big old glass window. So it's usually not too big of an issue. But the ultimate kind of piece of that is, you do what you can. And so have them push the lipid at the other hospital and then drive.
So something that came to my mind when I started thinking about a lot of stuff with calcium channel blockers, and honestly it stemmed from Dr. Marlin's thing yesterday. I was driving home and I was like, so we carry a lipid on the aircraft in a way, propofol. So if you've got a calcium channel blocker overdose, it's intubated. If you're trying to maintain down, even though it's a small concentration of a lipid, I get it. And you start talking about how propofol supplied, it's 100 vial, but it's still at least something. And y'all three are sitting here, you get propofol all the time. Do you think that maybe might help, or
It
do you
would.
think? Or do you
So,
think
so it's actually the bolus is the piece that matters. The bolus is the piece that matters because what is the theory behind lipid emulsion therapy is there's this lipophilic drug, right? It is going to naturally get its way into something that's lipophilic. And so you throw the biggest lipid magnet in the in the venous system as you can. So there's this drug that loves fat, and you just sent a massive fat wad flying through. It's going to jump in there and grab it. The premise behind the emulsion infusion is that it sustains that effect, but it can't initiate it because it's a pretty small effect.
so? Like that's what I'm saying.
So
like,
if you're using propofol,
in conjunction after you've had the bolus.
oh, I see,
Yeah,
as a post
not
thing.
yeah.
Actually, I don't think that would probably be too big of a deal, but I would always worry a little bit about the hypotensive piece of propofol. If that's what you're using to maintain sedation and the patient's tolerating the BP, it certainly is not hurting anything. And is it helping to sustain the that magnet effect that the body's kind of got going on there? Maybe. The literature doesn't really address specifically the replacement of the emulsion infusion with propofol, but it's not the most unreasonable thing. I think the concentration of lipid in propofol is less than 20%, and so you'd even be talking about a smaller volume. You'd have to be talking a larger volume of propofol just to sustain the typical dosing. But it probably isn't that big of a deal because the clinical toxicology recommendations for use of this is usually the 1.5 mLs per kg as a bolus over 3 minutes, followed by a 0.25 mLs per kg per hour.
Mm-hmm.
And then after 6 minutes, you're supposed to try to cut back to 0.025, which at that point you probably are pretty similar to propofol. Honestly. So I bet it would work. I don't know that there's any literature that has tried.
I'm sure there's not, but it was just a fun
calcium
fact.
channel block. But I think that's an interesting thought.
If we had enough
If
for
you
a
had
bolus, if I had enough for a bolus, and I didn't
Yeah.
have quite enough to do an infusion,
Yeah.
I was going from in Mississippi, we're going from the coast to here, and
Yeah.
it's a 2-hour transport, and I didn't. Hey, I'm trying to mitigate. Or
Yeah, you're already
at least give an
attempting to
extra little
maintain
buffer.
sedation anyway.
Would it work?
I bet it would. Honestly, the premise is pretty minor, or at the very least, unless the patient becomes profoundly hypertensive, I don't think it's hurting anything. And most of these patients, you're intubated and needing to maintain sedation anyway. And so almost everything you're giving short of ketamine is going to be altering the blood pressure anyway. And so you probably got them on stupid high doses of epi and norepi anyway. I bet it would work.
Might have to seek out our pharmacist.
We'll set up a study and just target all the cardiac arrest calcium channel blockers and just see if it changes anything. Good luck getting that through the IRB.
They're not going to go.
I'm sure it'll glide right.
It'll
on
just
through.
slide right on through. But it's interesting.
Moving on. So a couple other things that I want to make sure we get to. So Tylenol, it's super common. Whether it's unintentional dosing or intentional dosing, big deal as far as do you have acetadote and how much does it is and how long is it going to take and all those fun things. Any pearls y'all want to make sure we talk about with acetaminophen?
So I think you just need to say what you said is super important because it is. Like, it's a very common pediatric overdose. It is the number one cause of adult liver failure, period, by a massive margin. It's greater than 50% of adult liver failure secondary to Tylenol. And the next one is like 17%. So it is absolutely like a huge deal with regards to overdose and toxicity. So it is super important. But because of that, some people hear that and the first thing they do when they see somebody come in that says they ingested Tylenol is they get a Tylenol level. And it blows my mind. There is zero utility in a pre-4-hour Tylenol level. If you are worried that the patient took a supermassive dose, something greater than 10 grams in a kid, or something like that, and you're so worried that you need to know so that you can decide whether to treat him, just treat him. It's N-acetylcysteine. It's mucomist. It's not a big deal. Just treat them. It would be better for you to treat them than to
draw a lab that may potentially falsely reassure you and result in you not doing anything for the patient. But a pre 4-hour level doesn't mean jack. The Rumac methanogram is the standard of care in figuring out when the patient needs to be treated and when the patient doesn't need to be treated. And there's no data pre 4 hours, and there's never been data pre 4 hours.
You're not going to see all the bump lactates. You're not going to see necessarily LFTs and all.
Your coags should not change anyway for almost a day.
Yep.
Your LFTs take, if you look at the phases or the stages of Tylenol toxicity, you don't see LFT bumps for 4 to 6 hours. So it doesn't matter. So there's no point in drawing those things. If you worry that the patient took a massive overdose that is in the greater than 150 milligrams per kg, or greater than 12 grams or something, whatever is you're reading it off of, just treat them. It's N-acetylcysteine. It's not a big deal.
A lot of people don't know. You can get Mucomist IV. You can give it nebulized. You can give it both ways at the same time. So don't forget to give it appropriately. Give it early. If they are somebody, we've had a couple of cases, I know, in our team in the last couple of years where you're dealing with somebody that's Tylenol overdose 2 or 3 days later. They've sat in the ICU. Hey, they're not getting any better. We're going progressive liver failure. There was a late presentation to medical care is usually what it is. And yes, Brad's like, yep.
Everyone I've ever seen was late in the.
Treat them like liver failure for the most part. There's not a whole lot of different things we're going to do. Norepi works awesome. Be mindful of ammonia levels. Be mindful of all those other fun things that go on. Mindful of the respiratory acidosis component of that. If they are intubated, high rate, low volume, throw arginate in the max. Just try to make sure their minute ventilation is appropriate to get some of that acid off if you can. That being said, same thing if you're intubating them prophylactically. There's been a couple of them that are Tylenol overdoses that are from psych histories or intentional overdoses, and they're combative and they get intubated for that purpose. 12,505, you ever hear me say that coming out of my mouth and I'm talking about a patient that I did? Somebody knocked me upside the head, but make sure you're appropriately. Yeah, Paul would love that.
I'm here for
make sure you're appropriately managing your minute ventilation to match that and get some of that acid off. Another drug I want to make sure we talk about is Benadryl.
Can I give you another fun little medical history pearl? Has everybody seen the movie Airplane?
Yeah.
Right? Do you remember the name of the doctor?
No.
Dr. Rumac. Because the director or the screenwriter, I can't remember, of the movie Airplane lived right across the street from the Rumac.
Oh, wow.
The Rumac methanogram. So he couldn't put him in the movie, but he put his character in the movie. So the doctor on the Airplane movie is the Dr. Rumac.
That's pretty funny.
Benadryl. Sorry.
Yeah. Oh, no, you're good. Benadryl, another super common one. They're little pink pills. Everybody thinks they're Skittles. The Mad Hatter, pediatric.
So Brett and I we talk about this one a lot because it's kind of interesting. So it is not, we always talk about it as an anticholinergic, right? But it's not technically an anticholinergic. It's an antimuscarinic. Mm-hmm. So we talked about organophosphates, how they have the muscarinic and the nicotinic because they're a true cholinergic. True anticholinergics would have antimuscarinic and antinicotinic. So Benadryl is an antimuscarinic for the most part. But I'll tell you what, it can be a bad one because everybody thinks it's not that big of a deal, right? And so it's just Benadryl.
Super safe.
It's super safe.
Sleep aid.
I mean, if Sam's Club will make a 500 pill tub, it can't be that big of a deal.
Yeah, milligram per kilogram. It's safe.
It's not a big deal. So, but it really can be. And so I've seen some pretty terrible toxicities associated with it. This is another one that everybody kind of has their little mnemonic for: mad as a hatter, dry as a bone, blind as a bat, red as a beet. All of it just kind of say they're anticholinergic. These patients tend to be really delirious. They can be pretty darn combative. They suck to transport unless somebody has decided to take their airway for you.
Yep.
They tend to resist Ativan a fair bit if they get too much going on. And so I've seen people use just silly amounts of benzos trying to calm these patients down. So it can be a pretty tough thing. I've had a few go into cardiac arrest from the sodium channel blockade from the antimuscarinic piece. That's a pain in the butt to deal with too. But they can get really, really sick. I don't know why everybody thinks that they're hyper safe. If anybody's ever seen a paradoxical reaction in a 3-month-old that they tried to make quiet on an airplane, like,
Jeez Louise.
just imagine that in a 90-kilo 18-year-old you're trying to wrestle down to the bed. It can just suck.
The other thing I want to mention, again, interstitial losses, but these patients get dehydrated, it's not, they end up in rhabdo a lot.
Yeah, these patients end up in rhabdo a lot because they're so combative and fidgety and fighting, and they just are resisting everything you do. And so they can get, if you are like a lot of places that they try to physically restrain them, put them in leathers or something, and try to just hyper sedate them with Ativan, and they find out later that they can't do it, be successful. Yeah, those patients can get bad liver injury or kidney injury. I've seen CKs in the 60,000, 100,000, greater than whatever your maximum is, just from fighting. But it can be a pretty tough one. We don't see as, for whatever reason, we don't see as much of it as a principal overdose here. But where I was in fellowship in the Midwest, Benadryl was one of the most commonly ingested drugs that we dealt with for intentional overdose to try to kill yourself. I had a girl drink half of one of those Tylenol, or one of those Sam's Club tubs, and came in and started seizing within probably 40 seconds of hitting the ER door after punching out one of the techs. It was pretty impressive.
The last thing you kind of mentioned, it was sodium channel blocker overdose.
Yeah.
I want to make sure we talk about antiarrhythmics. When y'all think of sodium channels, especially in those kids, these are the ones that are going to go into VTAC and do all kinds of fun things and polymorphic, and your monitor does little dances that should not be normal. Are there things besides, obviously, sodium channel blocker, great, give them sodium, but are there things that you guys worry about, especially with pediatrics, with giving those kinds of things?
So a lot of these, you're given a lot of sodium to overcome it, and so it can create some other issues with cerebral edema kind of processes, or I guess I should say central pontine myelinolysis, whatever. But you're given a lot of sodium, and so sodium bicarb, sodium bicarb, sodium bicarb, sodium bicarb, or if you have it, my personal favorite way to try to do it is hypertonic saline infusion. I'll give them 5 mLs per kg over the first 20 minutes, and then I'll put them on an infusion and just run that junk and get their sodium up to 150 and just try to keep it there. But it's better for the heart, but having a sodium sitting up that high, especially if you have to rapidly change it in somebody who may have been 131 an hour ago, that can do not necessarily great things for the brain, but shockingly so does cardiac arrest. So it's it is what you get what you get. I find a lot of these, and I don't know about y'all's experience, that defibrillating them seldom fixes anything, because the cardiac tissue is so disrupted by these antidysrhythmics.
It makes the battery die faster on the monitors.
That's true. Then you don't see the dancing. But these tend to be pretty bad. I've seen some pretty rough codes with flecainide overdoses, for example. But you can see pretty huge swings. But getting that QTC closed as fast as you can is the only thing you can do to help.
That's the biggest thing to look for, is those EKGs. Even though sometimes in a cardiac arrest or in peri-arrest, everybody's like, oh, EKG is the last thing I want to think about in a kid, because it's a kid, it's not a STEMI, it's adults. It's got to be an MI, we got to look at it. Looking at the QTC in a kid to say, hey, this is really, really big, this is really where I immediately, my head automatically goes to sodium. As far as the tox thing. How much sodium bicarb are you going to give?
Well, I was going to say what he was talking about, with their sodium getting up to 150s level, that's something that we had actually transported a child that had overdosed on flecainide some years ago, and after we reviewed it with Brett, the kid did fine, but we were kind of digging deeper, well, what would we have done if this would have happened? What would we have done if this would have happened? And that was what we were concerned about, was the increasing sodium. And his thought was, it's a sodium channel blocker that they overdosed on. You could actually give a competing sodium channel blocker like lidocaine to actually compete with that flecainide in hopes of stabilizing their EKG, or stabilizing their. It was very interesting to hear him talk, and he talked about that yesterday. That was an interesting thought of, once you start getting to that point of being concerned with hypernatremia, maybe trying something different. And,
Like what, 155?
yeah.
He said anything greater than 150 to 155, you can consider. Lidocaine was his first line because it's something we're all familiar with. We all have it. I wouldn't consider, again, we're not giving true medical advice here when we're talking about this stuff, but consider more the infusion than you would. We're talking off a left stream here, but consider more of the infusion than you would the push dose of cardiac lidocaine.
1,000%. Because if you look at these in the textbooks, one of the things it says is do not give.
Yeah.
But we're talking about toxicologic emergencies and patients who are breaking. Like if you're just trying to close, if these are situations when the patient's arresting, right? We're not talking about you had a flecainide overdose, the QTC is really long, you gave a bunch of sodium, and the QTC is still not closed. I'm greater than 150. Let's just start giving lidocaine. That's not what we're talking about. Brett's talking about in patients in extremis who are broken and you can't fix them. Before you call it done, consider some alternatives. And so there is some stuff out there for those patients that kind of, usually they're small case reports or case series where this has been somewhat beneficial. Sometimes it's really just about the pharmacology and thinking about how these all work. This in almost like what we were saying with the propofol. Should it work? Probably. Does it? I don't know technically. But could it work? Could it help? And again, everybody in emergency medicine forever and in pre-hospital care has always said, once the patient's dead, you can't make them deader than dead. So anything you do that may potentially help. And so will it fix it? Who knows, honestly. But is there some small literature out there that says that it might? Yeah. And if the patient's are resting and their QTC is so wide that you will never successfully cardiovert them back out, you will never be able to defibrillate them back into a normal sinus rhythm and stay there, and you've got their sodium all the way up above 155 at this point, like, what are you going to do? Might as well just give it a shot, see what happens. I mean,
something interesting that Brett brought up yesterday was alternative purposes of bicarb. So bicarb shortage has been a thing, just like everything else in this world with supply stuff. How much or what you can use as a mitigating effect. So for us, we have access on the airframe and all the ERs 3%. Hospital, y'all have 7.5 and 21, all 23 and all these other things. For basically it's a 2-to-1. So for every 50 cc's of bicarb, about 100 cc's or so of 3% is the equivalent sodium load. So if you ever get in a jam and you at least got 3%, hey, you can give double whatever you would a bicarb, and that give you the same amount of sodium load as far as working on these sodium channel blockade overdoses. Y'all got anything else you want to add as far as drugs? A lot of stuff is simple fix, but it boils down to the ABCs. If you can fix the airway, breathing, circulation.
Because the polypharmacy stuff is what people ask a lot, especially if you don't know some of these, going back to that Skittle party thing. And this is what I said earlier is, like, I tell my fellows all the time, toxicology is super easy and also super complicated. Because the ultimate reality is, if you're in pre-hospital or if you're in community ER and you just don't know, you just manage, like, if they are in CNS or respiratory depression, take their airway, make sure they're not hypotensive before you do it, or at least as not hypotensive as you can possibly get them. If they're having a hard time oxygenating, maximize your vent settings. If they're hypotensive, if they have a fluid problem from a circulation standpoint, address their fluid issues, plus or minus. Pressors. Pressure sometimes is a little bit of a harder question when you're dealing with a completely unknown polypharm overdose, because sometimes they can affect things poorly. That's why a lot of times people gravitate towards norepi for the unknown polypharmacy, because it doesn't affect the heart. It just affects the vasculature. And so there is some benefit to just avoiding touching the heart if you can. But if they took a bunch or you absolutely can't figure out what it is, it doesn't fit a rhythm, airway, breathing, circulation, and then get them transported.
in as safe and as a reasonable a way as possible. It's ultimately not any of our jobs, even, and I, like I said, I work here. I work at a tertiary quaternary care center. Like, it's not ultimately my job to figure out what they ingested. I just treat what I know how to treat. Get your EKGs on every single ingestion. Get your airway, breathing, circulation under control on every single one of these situations. If their QTC is 600, close that QTC. And, whatever you have to do, you don't need to know absolutely every single one of these, and you don't need to know absolutely every single antidote that's out there. Know how to manage this supportively. Know to call poison control, to notify somebody. Get a toxicologist if you feel like you need to. But I'll tell you right now, like, for those unknown polypharmacy overdoses, you call poison control, you ask to talk to the toxicologist. I'll tell you exactly what they say: supportive care until we know what it is. Like, there's nothing else. Like, so that's the ultimate, like, most important piece to that is manage the airway, manage the breathing, manage the pressure, and then make sure they're not, like, about to go into cardiac arrest because their EKG looks like garbage. And everything else is probably something that somebody else can deal with. In ATLS, they teach all the time, if you cannot definitively manage the patient, don't keep playing with the patient. Don't do CT scans, don't do all those things. Kind of the same thing for a lot of toxicology. If you don't have a clue what you're dealing with, you know that you cannot ultimately be the tertiary place that is ultimately managing this. Get all those other things under control and get them out of there. You don't need to wait for their urine drug screen.
I was just about to say
You
UDS. Don't bring a UDS
their
into
ethanol. You don't need to tell me, any of those other things. You just need to control the airway, breathing, circulation, get an EKG, and stabilize them as best you can, and set up for transport.
Well, and Paul brought it up yesterday. We were sitting there in a conversation about how UDS can be a false positive.
It is absolutely a wasted test. It literally means nothing outside of a legal stuff, which we are doctors and paramedics and people that are treating patients. So we are not under any legal obligation to participate in the forensic gathering of evidence. So we should not be doing urine drug screens for police purposes. That's for the police to deal with. So it doesn't affect you from that side of things. And there are very few circumstances where knowing the fact that it was X drug will dramatically change your management in the emergency setting from supportive care stuff. So there's almost never a circumstance where a urine drug screen is truly, truly, truly a game-changing clinical practice change. So I don't ultimately care what your urine drug screen is. And most toxicologists would tell you the same thing. And yeah, the list of things that can false positive on a UDS is impressive.
Right. Wellbutrin is one of the ones.
One of the stupidest ones. Your barb will come back positive if you've recently taken Motrin.
Yeah.
Like, and all of these are like, and they're all enzyme specific. So whatever your different assay is that you're using has a whole, if you go to their company and you request information, they'll give you a whole list of things that test positive on their particular assay. But like, it doesn't mean anything. There are so many things that test positive on those. And so I don't want to know like what your urine drug screen came back as. Don't make the patient sit in your ER and wait until their UDS comes back, because nobody ultimately cares.
I love that you kind of summed that up like that, because I tell, when we have new people, I tell them all the time, with just about anything, don't get too far in the weeds with your patients. No matter what it is, treat what you know how to treat what's in front of you, but don't overthink it a lot of times, and don't get in the weeds.
And tox is one of those subjects it's easy to do.
100%.
Oh God, yes. I mean, we talk a lot when we teach toxicology, and when we do board stuff for it, we're talking about PKs, and we're talking about modes of elimination and half-lives and all that stuff. And yes, can you get into all of that? Sure. And at high level, like some sort of quaternary institution, does that probably matter for somebody not in the immediate setting? Like, yeah, absolutely. Like, probably the PICU cares. But like, if you're
emergency medicine,
ER, if you're in most ERs, like, you honestly don't care about that information. Like, I get ragged on a lot because I very seldom will call the toxicologist. Not because I don't think they're smarter than me, because they are. And not because I don't think they know more about these drugs than me, because I do. But I know that in the emergency department, it doesn't change my management. Right. Much of the time, I'm going to be doing supportive care and admitting to the hospital. and the upstairs people can call the toxicologist because it might matter to them. But in the emergency care setting, a lot of your management is supportive, especially for those unclear polyform things. It's supportive. Now, there are, like we talked about, some of those specific environmental things where if you don't do things right from the get-go, like, things can get hairy. And if you have a decompensating patient, then you should always call for backup for people that know what they're doing. But if you can stabilize, and GTFO, like.
I think you're right. I mean, the biggest thing to me is don't wait to start to have your patient fully stabilized before you arrange for treatment. To me, you need to be aggressive with, hey, let's go ahead and try to find some transport now. It may be an hour or 2 hours before you can get an ambulance. Does this patient need to go by air? How quick can we get somebody here? What is the minimum amount of stabilization we need to get done so that we can get them out of here and get them to your point, to that tertiary center that needs to receive them.
I love the phone call from somebody out in the state that's like, I'm dealing with this. They're sick as, whatever word they choose to use on my recorded line. And I'm working on stabilizing them, but I need a helicopter. And I'm like, yeah, we're going to start flying in that direction. And I know that they're not going to scoop it. Y'all aren't going to scoop and run. You're going to stabilize the patient. But, like, sometimes it takes a minute to set up stuff like that. And I would rather you not wait until, on that organophosphate, like hydrocarbon.
Waiting on a chest X-ray and a drug screen.
Somebody said we've been coding for 40 minutes. What else do I do next? I'm like, what the heck? I understand that, sometimes we get stuck in those situations, but like arranging that early process and thinking ahead a little bit, and like even if you just got to send like the tech or the janitor to like, can you go
tell them to call Medcom,
call 984-4367 and tell the UMC I need a helicopter, and we'll be like, all right,
no problem.
Sum up a few things with tox real fast. Biggest thing is decon. Make sure you're safe, make sure the patient's safe, make sure the downstream care team is safe. And then supportive care. I always think ABCs. There's a whole bunch of stuff we talked about today that's super high speed, super down in the weeds, super left field, if you will. But always look at your patient, treat your patient, reassess your patient. You should be good to go.
Don't get in the weeds.
But do reassess.
Do
reassess. Nothing makes me more concerned than somebody comes in. They slept the whole way here. Like, oh God.
All right, guys. Appreciate your time. Thank you.
Thank you.
Enjoyed it.
This has been a presentation of Blue Crew Medicine.